work to create a world
that's free of infectious diseases.
We work to make sure
that no infectious disease
is left unchallenged.
We discover, develop,
implement and evaluate
health solutions,
working alongside the most at-risk communities.
Doing so ultimately builds
a healthier, safer world for everyone.
We are the Kirby Institute.
I now would like to introduce Dr. Meg Ryan, who's the Director of the Global HIV, Hepatitis and STI program for WHO. She's been in that position since February 2020. What a great time to start in a new job. Prior to that, she has She's worked in lower and middle income countries for over 25 years, in and with lower middle income countries for over 25 years, ensuring that people in those countries have access to HIV care and antiretroviral therapy. And so without any further ado, I'd like to invite Meg to join us. Thanks very much.
And I'm hoping inevitably either I'm Shannon Doherty, Meg, or Meg Ryan, but either one is fine. I'm actually Meg Doherty, not to be confused with the Doherty Institute. So there's many Peter Dohertys out there. I think this is the connection between being Irish and being an immigrant. And my family ended up in Boston. So thank you very much for having me here, and WHO as well. We had a wonderful day yesterday, and I'd like to start by acknowledging the traditional owners of the land on which we're here today, and my respect to the elders past and present. And I think from WHO, we certainly have a privilege always of being in a position where we can see in the data that are coming in from around the world, pull it together as the conveners, and also work with all the colleagues such as you. And I would have to say we've had a very long and very fruitful, very long and very fruitful relationship with the Kirby Institute from before when David Cooper was here, but certainly with all of your academic leaders here. You really have helped shape the WHO guidelines. And we realized yesterday during a presentation at ACON and others that perhaps WHO has been mimicking and taking some of the work from Australia for years without knowing that, in terms of the language around virtual elimination, which started in 2011, which I think we picked up probably only in 2013 or 2014. So I think you're out there in front, and we really are learning from you. So today I'll try to give you an overview of where we are with some of the strategic frameworks and how that is supporting elimination of HIV. And for us, we're talking about ending AIDS as a public health threat, where we are with the current global targets and policy adoption. And then I'll give you a bit of a sneak peek at what are some of the new things that we're going to bring to the IAS conference, which hopefully should help others as well as Australia on your goals towards ending AIDS transmission. What we know in 2021, we did a review of our previous global health sector strategies, and we have also integrated the work around HIV, viral hepatitis, and STIs. I think another nod to Australia, because you have been doing this probably before WHO. And when we look at the progress, I think for HIV, what we know across these three different infection areas, they're at very different stages. For HIV, we have very strong targets, great history of implementation, support in terms of donors and funding from the Global Fund and PEPFAR. But we may have a difficult time in terms of global elimination. Perhaps my mind is changing after being here. For hepatitis B and C, we've always felt that this is the lowest hanging fruit for elimination, where we have a cure for hepatitis C and a vaccine for hepatitis B, but yet we're far away because we don't have that donor support. And then for STIs, we consider it the ignored area of infections for years, and 1 million new STIs every day. And yet now we want to be able to maybe perhaps jumpstart some of the STI response and reaching targets based upon the good work that's happening in HIV. So we have very aligned strategies. We have our WHO Global Health Sector Strategy that takes us up to 2030, and it's integrated. It's looking across the health sector and across the three disease areas. We have a PEPFAR strategy. We have a global AIDS strategy. We have a UNA strategy. And I think in many ways, they're all aligned. And so in some ways, we're probably pulling in the same direction in the best way possible since many years of HIV response. You're probably very familiar with the targets, the 95, 95, 95 around testing, treatment, and viral load suppression. But there's also now 95 target for coverage of services for eliminating vertical transmission, combination prevention, having access to sexual and reproductive health, as well as the social enabler targets of 10, 10, 10, which also may be quite difficult to implement, but if anyone can do it, those here in Australia should be able to. Just briefly on our strategy of the global health sector strategy, we have a goal through our vision of ending epidemics and advancing universal health coverage, but also ending AIDS and the epidemics of viral hepatitis and sexually transmitted infections. So I think all of us are working with the same assumption that we're going to be able to at least control new infections and reduce deaths, because it's important that elimination is not just about reducing new infections, it's also about reducing deaths and having a long quality of life for people living with HIV. And we have those targets. People were asking, well, what would it look like at 2025? What would it look like at 2030? And we've defined those in our strategies, that an impact target of reduction of new infection for HIV would be around 330,000 new infections per year globally, and less than 240,000 deaths per year annual for HIV associated deaths. That's very ambitious, but when I heard yesterday, and I hope I'm not letting a cat out of a bag, that perhaps here already you only have 91 new cases in a year, it's countable. And I think that this is the kind of thing that we'd like to see as we move forward. Cities, regions, states counting the number of new infections that they have. So what are the kinds of shifts we might need to see? When we still have 1.3 million people acquiring HIV in a year, and that's the new report, and 630 people dying, we do have to focus on prevention. We have to look at deaths and reduce the new deaths, leverage whatever innovations are available, whether it's new treatments, long-acting prevention, address the stigma and discrimination. And certainly it's about not just ending HIV transmission in global populations, it's in all the populations, key populations, women, children, those who are traditionally left behind. So when we go to the where are we with the targets, I already gave you that overview that we were sort of stalling in the reduction of new infections during COVID, and we've had a bit of a dip, but we're certainly off track for making those targets. And also for deaths, we've started to see a decline when it was stalling, but again, still not steep enough to be able to reach our 2030 targets. And when you start to look at what's happening in the new infections, you can see there are many countries, those most high burden, those with the greatest investment, either from PEPFAR, Global Fund, or domestic resources, are seeing a very steep decline in new infections, whereas you're still seeing in parts of the world increases. And those may be in low burden settings or in areas and countries that are not investing in their HIV. And I think also in this region here, there are some parts of the Western Pacific where you're seeing that kind of still increasing HIV infection. And here, this just gives you a sense that there's variability in new infections across the globe. And when you take a look at just the Western Pacific, we've seen decreases in deaths, but overall increases in the WHO Western Pacific area. So there's one or two countries that may be driving this, but it's important as a region that you think not only about where the setting is, but how that impacts the region and how one could actually work towards reducing new infections in the regions, because there's a lot of in and out migration of every nation. And when we look at who has the highest risk, we're seeing this across the board. People who are in the key population groups, sex workers, MSM, people who inject drugs, transgender people, people in prisons are driving the new infections. And overall, over 90% of new infections outside of sub-Saharan Africa are in the key population groups. So that means the work has to be focused in those groups, and stigma and discrimination needs to be addressed. Busy slide, but I think this comes from the new AIDS report that just shows, to be honest, on the 95, 95, 95 targets globally, one could say we're at 86, 76, and 71, the best we've been ever, and it's gone up since 2015. And now there are 5 countries in sub-Saharan Africa that have reached those targets. But do reaching those targets mean that the incidence has decreased and that we're controlling and that we're at the end of AIDS as a public health problem, or have we eliminated HIV transmission? And I think the answer there is no, that we need to be, because in these countries, you'll also see a real differential among children, where children have been left behind, where the viral load suppression for children is about 46% here. And if we look over to the Western Pacific region where you're located, you're doing quite well, but you have neighbors who may not be doing as well. So just to get a sense that there's differentiation across the board. Another thing that WHO tracks is to see how are our policies being implemented, either taken up, implemented with full fidelity. Why? Is because we think if the policies that we've put out, the guidelines that you all have contributed to, are taken forward, that will contribute to your elimination targets. So I've picked a few. When we look at pre-exposure prophylaxis in national guidelines, the green means good, orange means policy not adopted. Green is policy adopted and implementing. And it's great that the policy gets adopted, but when you look a little bit more in depth, you can see that actual full utilization and numbers of PrEP have not gone up as fast as they would need to go. And in the Western Pacific area, excuse me, that's Egypt, pardon me, Europe, pardon me, here, I may not have it right. Oh, here it is, Asia and Pacific, where you would need to see the target, the PrEP, you're way off the target as a region, and meaning that you're probably not getting the benefit from the PrEP. Could it have been scaled faster? In terms of self-testing, we discussed this yesterday. Having options that people can test on their own in their privacy has really revolutionized COVID. It's revolutionizing pregnancy and others. It should revolutionize HIV, hepatitis, syphilis, etc. And we can see that HIV self-testing and implementation has taken off quite a bit in Africa, but there are still other areas in the world that have not yet really addressed this self-testing implementation. Another area where especially the Kirby Institute has helped WHO is discussion around the antiretrovirals to be used in first line, in second line. And I think there has been a real dramatic shift to using integrase inhibitors or dolutegravir. And you can see here, dolutegravir is taken up almost everywhere in first line. In second line, a little less utilization, but if it's there, it might be helpful for bringing people forward to having full viral load suppression. But we're also seeing a real disconnect between dolutegravir being used for children. Again, something that should be emphasized also in this region, even if there is a low burden of pediatric HIV. When we look at community delivery of antiretroviral, this means getting it out with community healthcare workers. We're not seeing full implementation, and much more could be done there, because we know when antiretrovirals, any medicines are taken closer to home, the likelihood that people will be maintaining their adherence, etc., would go up. And lastly, advanced HIV disease. We've had a package and a guidelines for many years, at least 4 or 5 years, but it hasn't necessarily been implemented with fidelity. So even though we have policies being taken up, it's a package that talks about TB, cryptococcal meningitis, addressing bacterial infections. And what we see is very rarely do we find it fully implemented around the world. And if that did happen, we could probably see a more dramatic drop in the number of deaths every year. And lastly, viral load testing. We've been asking for and had a guideline, a recommendation on utilization of viral load monitoring every year since 2013. Still, we have places where people are not able to access a viral load even once a year. So if we want to optimize the ability to utilize the messages around U equals U, we have to have better access and better utilization and clinical utility around the viral load, so that if a viral load is elevated, it can be acted upon, or people can know their status. Often you have people getting a viral load, never knowing what the result is. And we saw that recently in Thailand, they have a very strong U equals U message. However, up to 30% of those who have a viral load never receive the viral load themselves. The doctor has it or the laboratory has it, but not the person who needs it. Now I'm going to switch gears and give you a little bit of a sneak peek of some of the guidelines that we have out that could be helpful for achieving or trying to achieve the virtual elimination or the elimination of HIV transmission, but also what we'll be bringing to the conference, which might also be contributory to some of the work you'll be doing. If you haven't seen it, we call it new, but it came out last year and it was launched at last year's IAS conference. Is this first time we've done a comprehensive guideline for key populations across HIV, hepatitis, and STIs. And it speaks to prevention, diagnosis, and treatment, but it also speaks to enabling factors, community empowerment, addressing violence, reducing stigma, and addressing laws. These guidelines were developed with key populations and pretty much by key populations. So these are very innovative set of guidelines. And this is a busy slide, but it really speaks to all the very different services, the enabling interventions, and the broader health interventions that are identified and discussed within these key population guidelines. So I just encourage you to take a look at them online. We also have updated our PrEP implementation guidance, essentially giving PrEP the capacity for people to use PrEP as they would like to use PrEP, either having it as event-driven PrEP, and really looking at the approaches for reducing the amount of barriers, reducing the testing, reducing the kidney function monitoring, using self-testing in between PrEP, having a differentiated PrEP delivery, and also thinking about how one can use PrEP and also viral hepatitis. And certainly that's important for populations who are injecting drugs. So I would also encourage you to look at this, because this should simplify and make PrEP more accessible, especially for scaling up in the region. We made a recommendation as well around long-acting cabotegravir that came out last year. Now, it's exciting that we have long-acting cabotegravir. It's shown to be, a real game changer. People want to use it. However, right now, it's challenging to access. And I don't know if you have much of it here in the region, but we only have, I think right now, 4 or 5 countries that have gone through full regulatory process. And although it's approved in US, Australia, Zimbabwe, and South Africa, we do know that there may be some issues in being able to use injectable PrEP regularly. I think there'll be some good studies that will come out and show the acceptability of using injectable PrEP at the conference. We also at WHO have been thinking about PEP. You know, are we using PEP when we should be able to? The pre-exposure prophylaxis. We've had recommendations on this for years, but we find very little data that it's being used effectively. Could there be a PEP to PrEP pathway? But again, looking at many of the different options for prevention, and especially if this is a goal of Australia to reduce your new infections, utilizing whatever prevention modalities you have, I think will be helpful for getting to that, getting to every last case in person. These are now I'm going to give a smattering of things that will be shown on the 23rd of July. So a little bit of a sneak peek, not really embargoed except for 1 or 2 slides. But we have new testing guidelines or recommendations that will be shared at the meeting. One is self-testing can be offered as an additional option in facilities. So trying to increase the ability of overcoming stigma, letting people test on their own, even in a facility. It can be used during PrEP and social networking testing. And you'll have Virginia McDonald here from the region who will be making a presentation on this in a plenary at the IAS conference. We have dashboards where you can go in and actually look at things like men's testing, other service approaches, and also self-testing in the workplace. The other is dolutegravir. I think this is a busy slide, but just to show the market has completely changed around what are the first line ARVs and even the second line ARVs. So during a period of time when I first joined WHO, efavirenz was the regimen of choice. Now what you'll see is almost 94% of the market is now on dolutegravir. And essentially what we need to do is protect the dolutegravir, and that's a challenge with potentially long-acting cabotegravir as prevention. But also as we wait for the pipeline, which is not as robust as it used to be, I think it's important to think about how do we ensure that we protect that dolutegravir. And especially for children as well, where it's starting to come out, but yet that transition has been slow. If we want to see that viral load suppression of 46% for kids to go up, not only do we have to identify children earlier, but having them on a robust regimen, such as a dolutegravir regimen, dispersible tablets, is the way to go. And so bringing in those new regimens can be difficult because they're often harder to find and they're low volumes. This is a nice slide that comes from USAID, and they followed their viral load suppression across their PEPFAR countries once they introduced dolutegravir. So this is the total amount of dolutegravir that's being given, and this is the viral load. So essentially when a country goes from low dolutegravir infusion, one might say, to higher, the viral load suppression rate goes up. So in many ways, we know that using this regimen right now has been very helpful for gaining us and getting us closer to really understanding a U equals U and implementing a U equals U, and ensuring that if you're going to reduce new infections, it's not just PrEP, it's not just prevention, it's having everybody who is HIV infected on life-saving therapy that reduces their viral load. And this is a good way to achieve that. I just wanted to nod out that Nadia and DEFT in particular have been very helpful for us in the trial. So I know that the Kirby Institute has been very much involved in the DEFT-2 trial. And in terms of being able to both use dolutegravir in second line or use darunavir, ritonavir in second line, we're thankful for the work that you've done. And in late 2023, early 2024, we'll be revising and revisiting second and third line. Lastly, just to say, we are looking always at resistance. And we've just had a meeting on HIV drug resistance, and we've also looked at now hepatitis resistance for Hep C drugs, as well as Hep B drugs, and STI resistance. We've put out a report almost every year now, And we're starting to hear reports around dolutegravir resistance, very few, very low level. But if you recall, we watched the efavirenz resistance for a while. And when it hit a certain threshold, that's when we decided that we needed to make a switch and a change for public health response. This is the efavirenz resistance. And I think there are some countries within your wider region who are struggling with that. And you know the countries that the country I'm speaking with about. And I think whatever we can do to make the transition to dolutegravir first, and then also set up the monitoring to be able to ensure that we're looking all the time for any weaknesses in the dolutegravir. And we haven't seen any issues yet, but we're starting to see it reported from sub-Saharan Africa. Lastly, we're also have guidelines around how to keep people in treatment for long term. And one area that we've recognized and everybody has is that integration of some of the wraparound holistic healthcare services are important as people age. So we have recommendations about taking your medicine home every 6 months, if feasible, coming to the clinic every 6 months, if feasible, and then having those other services, diabetes, hypertension, sexual reproductive health services, ensuring that there's re-engagement for those who have fallen out of care, and also psychosocial and mental health interventions. That package is going to be essential as you look towards ending AIDS as a public health threat. And I think it will encourage more men and others who have fallen out of care to be brought back into care. Lastly, just to say, we have lots of recommendations and guidance coming out about integration and how do we start to think about the sustainability of an HIV response and serving people where they are in their holistic needs. And I think that has been part of the work that we're bringing to IAS. So now here's the real sneak peek. And I'm going to highlight 3 products that we are taking and that will be shared at our satellites that will be on Sunday. But at the same time, just so you're aware, we have a whole nother team going to the big STI meeting in Chicago, and they're bringing a number of new guidance documents around the testing and the diagnostics for STIs, as well as how do we handle drug resistance that's emerging, especially in this region around gonorrhea. So the first document I want to highlight is there will be, and this is the embargoed one, so please don't take a picture or share. I might get in trouble because embargo is on the 23rd, but I think here in this group, you can ensure that we're not talking too much about it. There will be a new systematic review about transmission at different levels of viral load. And can we concretely say that the viral load level that WHO has been putting out there of 1,000 or less, is that strong enough to say we don't see transmission happening? And I think the studies that have come up have shown that essentially we're very clear that transmissions do not happen at what we call an undetectable load, viral load, which is at the levels that are undetectable by the actual machine used. And that would be less than 50, less than 25 copies. And we've defined what that is. Undetectable is just not detected by the machine and by the platform used. We've then also defined what is suppressed. Suppressed is detected, but less than 1,000 copies. And that would be by the fact that many of the point of care, many of those using DBS, for example, will only be able to monitor to 1,000 copies. And then we have unsuppressed, which has always been greater than 1,000 copies for us. And it's something that we're very worried about, that those people who are having an unsuppressed viral load need to come back every 3 months, potentially have enhanced adherence support, and then ongoing viral load to ensure that they maintain suppression or move on to another therapy or second line if needed. But essentially these messages here that using the WHO algorithm should be compatible with the U equals U message. And I think that's a strong messaging that will come out. We will also be sharing a document where my colleague Andy Seal, who's here in the audience, has really been the architect of this as well. How do we start thinking about the convergence between primary healthcare and HIV? And I think this is important to think through. If integrating HIV services or HIV planning and programming into primary healthcare and primary healthcare services is a future, I think we need to also ensure that we're sustaining and maintaining the excellent work of HIV as we move forward. So this document helps countries start to think about what that might look like. And certainly it's looking at the terminology, clarifying that we're using the right terminology, a primary healthcare approach, which is much greater than just the service delivery. Many of us, myself, always default to the primary healthcare services because we're thinking at where the facility level delivery of action is. But I think in many ways, getting this right will help countries as they start to integrate HIV. And there are many countries who are starting to do this already. And this document will help countries potentially take our HIV programming, look at the primary healthcare programming, and find a home for both of them together. And perhaps here in Australia, you could show us the way of how this can be done well. And I think this is about amplifying the commonalities, the people-centered approach, and really focusing the health systems towards achieving disease-specific targets while also having those wraparound services for the person living with HIV. My last point is really around the intersection of HIV and Mpox. And I know you also were quite active in the field of Mpox work. And I think right from the very beginning, our HIV department was brought in very meaningfully into the discussion around Mpox, and to ensure that not only do we have risk communication and community engagement right, but that we looked at the potential risks of people living with HIV. And what we have seen from the WHO database, and it will be presented as an oral presentation at IAS, is that people living with HIV fared worse with Mpox. And I think you've seen some of this globally, and it was mostly among the people who were unsuppressed. If somebody was on antiretroviral and actually had a suppressed viral load, they did just the same as those who were not infected. So again, more to be done about vaccination, access to information about long-term immunity. And I think in many ways, the answers are not yet final on what will happen with Mpox. Will we see a resurgence? And how do many have asked WHO to be thinking about, is Mpox or severe Mpox or disseminated Mpox a new opportunistic infection? And that's a process that we're in the middle of going through a process to be able to make those definitions. And lastly, this is a sneak peek of a really interesting community outbreak cross-sectional survey using the dating apps. And I don't want to say too much about this, but I think it was to get a sense of how much behaviors were changed. And what we can see is there were 16,000 people who got into this survey that was up for a very short period of time, focusing on Europe and the Americas. And there was, I'm just going to go to this one, there was behavior change. And I think the question now has always been, was it vaccination that stopped the outbreak? Was it behavior change? Was it, immunity that acquired because people were already in infection? And if I had to rank them, even though scientifically I don't think we have it on paper, I might put behavior change first, natural immunity second, vaccination third. But should we not vaccinate? No, we should vaccinate because we should be prepared for a next outbreak and something that might happen again in the future. And we don't know how long immunity will last. So I think this is another piece of good information around how, when engaging with communities, having good messages, addressing early, that communities know the answers, and that the researchers can just sort of wait and monitor it afterwards, because the community took care of this problem, I think, more so than WHO or I would say. But going forward, we'd like to be able to be sure that we're addressing Mpox everywhere, not just in high income countries, but also in Africa and other places that are less have less access to some of the interventions, and certainly where we saw the highest risk of death because of the lowest levels of immunosuppression there. So in summary, I think more countries on track for 95, 95, 95. I guess, do we need to add Australia here? I think what we're looking for in the future will be important to track not the 95, 95, 95 only, but by populations, by cities, by jurisdictions, address those inequities by key populations. Are you achieving those kinds of levels? And then really taking some of the specific steps, because I think reducing incidence is not just reaching 95, 95, 95. I think it's going to be much more and looking towards how you can monitor those case numbers. And we'd like you to implement those health sector strategies, bring the innovations, look at the 10-10-10, because I think these are also going to be some of the barriers to reaching those case numbers for elimination. But after the visit here, I'm much more, let's say, optimistic that we'll be able to stepwise achieve some elimination in some cities, in some jurisdictions, in some states. And I think that's exciting because it may re-energize what has been a bit of a flagging area of HIV, where we're competing for so many more resources. If we don't keep something engaging people's thoughts around the fact that we can get to the end of AIDS as a public health problem, we may not be able to continue doing what we've been doing for 20, 30, 40 years for many of us. So with this, I invite you to some of our sessions, and thank you very much. And thanks to my colleagues who provided me with all of the great information. Thanks.
Thanks, Meg. We'll stay here for questions. So we'll take questions from the room. If you come to the microphone, and please enter questions into the Q&A if you wish to. Could I start while people are doing that? What do you think are the commonalities between those countries that have reached 95, 95, 95? And are there, I mean, a lot of this is going to be site specific, as we discussed yesterday, but, you know, are there some generic learnings from this?
Well, when I look at the 5 in sub-Saharan Africa, we've got, if I have them right, we've got Botswana, we've got Eswatini, we've got Rwanda. Namibia is closer, if not there. So those are countries that I think had very high epidemics in the very beginning, but very small populations. And so they also had very strong ministries of health. They had strong political will, and they had strong financial engagement. So Botswana had their own engagement financially, as well as Namibia. But look at Rwanda, they got external support, but they've had a very strong leadership in their ministries. So I think that's one of the, they've utilized their funding really well to be able to address what needs to happen in terms of covering the full population practically. But that's because they have a smaller population. The challenges will be in the larger population countries, for example, the Nigerias, the DRCs of the world, the Kenyas of the world, where there may be more of a federated health system. Other commonalities, I think, may be that, you know, for a long time, it was primarily in a heterosexual population. When you look deeper now into what's happening in sub-Saharan Africa and around the world, even if the general population incidence is going down, you can sometimes see rising incidence among key populations, and in particular MSM. So I think the not taking care of ensuring that MSM are brought into and key populations are brought in meaningfully into the response will be maybe the Achilles heel of those countries who are already doing quite well.
So online, there was a question related to you using the words protect dolutegravir. So what did you mean by that?
It's hard to protect dolutegravir, I guess, because it's a very it has a very high potent barrier to resistance right now. I think what we do know is from the studies where dolutegravir was used alone without another agent with it, it didn't fare well. And I think there's WHO is traditionally a bit more conservative on moving into dual therapies, so I think for us, we would want to ensure that there was a maintenance of a triple therapy with dolutegravir. But I think the other protection element would be ensuring that people have their viral load. So if they are on a treatment regimen and not suppressed or not undetectable, that they change, and if maybe they need a second line therapy. And as we move into cabotegravir long acting, these are in the same class, that we'd have to be careful of ensuring that widespread use of cabotegravir wouldn't have an impact. And right now, the modeling and the evidence from studies are showing that it shouldn't have an impact, but it will be something that we will need to watch and monitor.
So Andrew.
Meg, thanks for a great presentation. I have a question about the effect of COVID on HIV trends. That, around the world, we know testing declined enormously, risk behavior in many settings declined, and in some places treatment was disrupted as well. So do you think we have a full understanding yet of how that's played out in terms of incidence and the cascade goals?
I think, there was some really dramatic modeling that we did with others in the very beginning, saying if we didn't maintain therapy, if we didn't maintain testing, we could have a disaster. There could be double the number of deaths happening due to HIV, especially in sub-Saharan Africa. And that did not play out, because I think communities really engaged, not only in COVID response, but also ensuring that people had access to their treatments. So I think what we did see is that treatments were maintained. What we don't know is sort of the counterfactual, how many people didn't get into testing during that time, because there was a lull in testing. But we have seen in some places, for example, PrEP go way up. So perhaps the use of prevention has also counterbalanced some of that loss of testing. There have been a number of analyses of testing, especially in sub-Saharan Africa, where most of the testing is happening globally. And there were a lot of competing factors, but yes, testing did go down. And I think it's starting to catch up, but perhaps our curves could have been more on a downward trend now than they were before, because we're going to be starting to see the impact of both having a very robust ARV and also self-testing, which should, democratize testing a bit more. So the answer is, in short, I don't know.
So we'll take two more questions, one in the room and then one online.
Just a small question. Hi, thank you for your talk. It's just about self-testing out of sheer ignorance, because a lot of times when I've seen self-testing promoted, a lot of people are very skeptic about how honest each person at their homes will be about the result of this. What have you observed? What's the evidence so far? If you mentioned a positive sort of outcome, especially since COVID self-testing happened. What's been the tendencies worldwide?
Well, I think in HIV self-testing, COVID self-testing, I think there's been a general acceptance that it's quite nice to be able to do some of these things, like testing a status of any infection in the privacy, where you don't have to be publicly acknowledging what's going on in your body at the time. I think it's accepted. And also we know with HIV, people may test 2, 3, 4 times before they really come to terms with the infection and go to see a healthcare provider. So if that can be done more rapidly at home, and then the time to getting to a healthcare provider to start treatment or that discussion of treatment can be increased, I think it has a great benefit. I'm not the expert in self-testing. If I had one of my colleagues here, she could tell you the increased number of, people showing up at clinics, but we'd be happy to get you that information if that's what you need, and if you'd like that. But I think all of us probably used our COVID self-tests liberally at home to protect yourself, to protect your family, to protect those you're getting on a plane with. So in many ways, think about it the same way. You'd want to know any infection you might have, and it's a real powerful self-care, I think, motivation. Yeah,
thank you.
Thanks. So the final question from online was, you talked about the brittleness of the ARV pipeline, and could you expand on that?
Well, I think in the past, we always were seeing a lot of new drugs coming down the pipeline and being very excited about what was coming down the pipeline. And I think we've been a little bit concerned that some of the drugs that we're excited about, lenacapavir, has some problems, islatravir have some problems. And I think we're waiting for the next best drug. It may take some time for those to come forward. And also knowing what to pair those drugs with will be an important piece for clinical trials going forward. I think it's good that for the treatment aspect of these drugs, they're moving forward in clinical trials, but prevention, I think it's been very disappointing. I think I'm going to get the wrong one, but lenacapavir wasn't able to continue, but islatravir is moving forward, or maybe I have them inversed now in my head. I have them inversed, but I knew I was going to get that one wrong. But I do think that, we haven't seen as many exciting molecules coming forward. Perhaps here at IS we'll have some new ideas. I do think that there's been a lot of investment in cure and other molecules, but those don't seem to be readily applicable to the millions and millions of people who need therapy. Thanks.
So Meg, thank you very much. And I think that performance at least equals, if not better, as any of Meg Ryan's. So thank you. That's now my great pleasure to introduce Dr. Skye McGregor, who leads the Surveillance Innovation Research Group here at the Kirby. Skye is an emerging leader. She's a great communicator and has transformed the way we do surveillance for HIV, the hepatitis and STIs here in Australia, and she leads those efforts. But she does more than just count things, and she interprets that data for us, but also is very involved in in innovating around intervening to change those numbers in a good way. So Skye, thanks very much for your presentation.
Thank you, Tony, for that very generous introduction, and thank you all for today, and Meg for a very interesting and inspiring presentation. We're going to shift a little bit from the international perspective and come back to focus on Australia. It was just there. Beautiful. Thanks, Sam. So we're going to talk about Australia's progress towards ending HIV with a focus on the last 10 years of surveillance data, now that we have the 2022 data available. And an enormous thanks to the states and territories who have provided these data in a really timely way this year, so they're available for the conference. So first, of course, I'd like to start by acknowledging the traditional owners of the land we're on, the Bedegal people, and pay my respects to elders past and present, acknowledge the continuing connection to land, culture and water, and extend that respect to any Aboriginal and Torres Strait Islander people here today with us. I'd also like to acknowledge people with HIV. In Australia, the response to HIV has very much been characterised by a partnership between community research and government. But people with HIV have been at the centre, their perspectives and the incredible wealth of data that have been used to ensure that we can have an agile and evidence-informed response in Australia. So this figure shows us HIV notifications, and what we mean by this is people with the first ever diagnosis of HIV in Australia, and that distinction will become important later. And it means people who have gone to the clinician, had a diagnosis, and then been notified to health authorities, and those data are provided to the Kirby Institute for analysis. And so we can see, looking at the purple line, this is notifications. Oh, that's a wolf in a suit. I don't know if that's foreboding. That is the right one. Thanks. Okay, great. Let's get back on track then. So the purple line shows us notifications overall, and we've used the baseline of 2010 because this is the UNAIDS target of a 90% reduction in notifications, which represents the elimination of transmission is what we're aiming for. And what we're talking about is sustained reduction in local or endemic transmission. We're not talking about HIV being eradicated from Australia, and that's important to remember too. What we see looking at the purple line is there was 555 new HIV notifications in 2022, so stable numbers from 2021. But this represents a 39% decrease overall since 2010. We can see looking at the brown line that the decrease has been greater among men at 42% than among women at 23% in the blue line. And what this reflects is larger declines in people reporting male-to-male sexual contact. And I'll talk about that in more detail in the next slide. But also it reflects a tremendous uptake of testing, treatment as prevention, and pre-exposure prophylaxis. Looking at the 10 years, which the rest of the slides will do, is a 46% decrease since 2013. And also you can see a 38% decrease since 2019. So this last few years likely reflects the impact of COVID. And we just talked about that briefly with Meg. We know there's been interruptions to HIV testing. There's evidence of reductions in risk behaviour, but also we saw a restriction in the movement of people in and out of and around Australia, which also likely impacted those numbers. So this figure shows HIV notifications by exposure. So the most likely route of transmission reported at the time of notification. And on the left-hand side, we have the 2013 data, and on the right, the 2022 data. And each of these people represents 1% of the total number of notifications for that year. So we can see in the green, those notifications reporting male-to-male sexual contact. And for both years, they represent the majority of notifications. But we have seen a shift in this over time. So in 2013, they represented 79% of notifications, whereas in 2022, they represent 57% of notifications. If we compare this to the orange, which is people reporting heterosexual contact, there were 21% of notifications in 2013 versus 30% in 2022. I think it's important to note that this doesn't mean a dramatic increase in the number of notifications reporting heterosexual contact. Rather, as we've seen that dramatic decline in notifications reporting male-to-male sexual contact, the heterosexual ones make up a larger proportion of the total. And what we see is, you see in those points, we've seen a 57% decrease in the notifications reporting to male-to-male sexual contact versus a 25% decrease among those reporting heterosexual contact. And again, this is from 2013. If we look at the blue, this represents people reporting injection drug use, and you can see in both time periods a very small proportion of notifications. And so we've seen sustained low numbers among people who inject drugs and sex workers, and this is really a credit to the Australian response, because this is not what we've seen in other parts of the world where there have been very large numbers in these two key populations. The pink represents other, and this is an accumulation of a number of different exposure risks, including vertical transmission, contact in a healthcare setting, blood transfusions, but the vast majority of these tend to be overseas acquired, but then diagnosed within Australia. This shows the notification same 10-year period by state and territory. And so I'm not going to go into them in detail in terms of the numbers, but what it just shows is that New South Wales in the blue line, Victoria in the brown line, Queensland in the purple are the majority of notifications, and they have been for each of the last 10 years, followed by Western Australia, and then a small number of notifications in the other jurisdictions. What we see is decreases in all of those jurisdictions over the last 10 years, ranging from 27 to 86%. We've seen in 2022 small increases in Victoria and Western Australia, but I think we need to consider that in the context of what the COVID restrictions were in certain jurisdictions and a resumption in testing practices potentially associated with those increases. But I think it's important also to pause and think this represents less than 200 cases per jurisdiction in the last 2 years. And these really are small numbers when we reflect on the global numbers. And I think we need to pause and celebrate this tremendous success in Australia. Looking at the data by place of birth. So in the blue line, we see Australian born. And what we can see over time is that they represented 59% of diagnoses in 2013 versus just under half in 2022. And if we can compare this to the overseas born, we can see there hasn't been as much change. So for Australian born, there's been a 55% decrease in that 10-year time period versus a 33% decrease in overseas born. And what this suggests is potentially those amazing successes we've seen among gay and bisexual men are focused among Australian born, and we need to do further work to ensure that overseas born people are experiencing the same prevention and treatment access equitable with the Australian-born population. And this might mean working with populations, including people from culturally and linguistically diverse backgrounds, ensuring that we're co-designing approaches that are appropriate for communities at risk. This figure shows notifications among Aboriginal and Torres Strait Islander peoples for the last 10 years. And you can see in 2020 and 2021, we had a small number of notifications at 16 and 17 respectively. In 2022, we have seen a slight increase in those numbers to 25 new notifications. And while the numbers are smaller than the overall general population, any increase in this group is concerning. And we need to ensure that we're working with communities again to understand what the requirements are. And we need to understand the context, particularly in some regional and remote settings, of the challenges of accessing healthcare for people and therefore appropriate care and prevention. Now, the distinction I made about diagnoses, first ever diagnosis in Australia, and is important here. So this slide, we often don't look at these data, but this is people who've been previously diagnosed overseas. So they come to Australia, they're aware of their HIV status, they engage with a healthcare provider, and those data are still notified to us at the Kirby Institute. And what you can see compared to the first ever diagnosis is that these numbers have increased over time. And so we've seen a 60% increase in people previously diagnosed overseas since 2013, that dip likely because of COVID and restrictions on the movement of people. But the reason I show these data is to further highlight that elimination of transmission of HIV isn't the end of the road. There are still people with HIV who need appropriate care, support and treatment, including people with a first ever diagnosis in Australia, but also people who are previously diagnosed overseas and moved to Australia. The data we collect also enable us to determine stage of HIV diagnosis. And this figure shows late HIV diagnoses, and it's broken down into a number of groups. And so we can see, and just a reminder, sorry, that late HIV diagnosis means diagnosed with a CD4 count of 350 or less. But what we see looking at the brown dotted line is overall in 2022, 44% of people were diagnosed late. So still a really large proportion. But this increases to almost 60% among people reporting heterosexual contact, slightly lower, but still high among overseas born, but decreases down to 37% among Australian born and people reporting male-to-male sexual contact. So again, I think this shows our differential response in Australia, and echoing comments from Meg that we really need to focus on equity now and ensure that everybody who requires it is able to access appropriate care and treatment. And this is about timeliness of HIV diagnosis and ensuring some of those strategies Meg talked about in terms of self-testing and things like that are supported and help people to engage early in care. To support those data in terms of timely diagnosis, we look at the proportion tested for HIV, and this is in the last 12 months. And these data come from the Australian Collaboration for Coordinated Enhanced Sentinel Surveillance, or ACCESS. And the top 4 lines are people attending sexual health clinics. So we can see in the purple line, gay and bisexual women, in the blue line, female sex workers, in the brown line, young heterosexuals, and in the pink, people who inject drugs. So what we can see is that the HIV testing coverage among gay and bisexual men and female sex workers is very high at around the 90% mark, slightly lower, but still high among people who inject drugs, and then drops down to around the 50% mark for young heterosexuals accessing sexual health clinics. If we look at the dark blue line at the bottom, this is young heterosexuals accessing GP clinics, which is down to 6%, so low testing coverage. I mentioned the impact, and we talked about before, of reduced HIV testing in terms of COVID. And from first glance of these data, it looks like actually there hasn't been much drop off in testing. But if we look at the context of it, actually there's a lower number of people attending clinics. So even among those people who attend clinics, the high testing coverage has been sustained. What we see for these groups is between a 7 and 44% drop off in the number of people attending the clinic. So actually the absolute number of people tested for HIV has reduced in that time. And combined, I think these data support the need for accessible testing with a range of options, allow people to resume their pre-COVID testing patterns, talking about normalising of HIV and conversations around HIV, and a really important role for the ongoing reduction in stigma around HIV, so people feel comfortable having conversations around it. Meg spoke about pre-exposure prophylaxis, and these are the data for Australia. So this is prescriptions from the pharmaceutical benefit scheme from 2018, when subsidised PrEP became available in Australia. And so if we look at the brown line, this is people who have ever used PrEP, and we see nearly 63,000 people have been dispensed PrEP in Australia. Of those, 98% are male, reflecting the really high uptake among gay and bisexual men. If we look at the pink line, which is PrEP use in the last 3 months, we can see the impact of COVID restrictions. So those dips very much align with lockdowns in Australia. But encouragingly, if we look at the blue line, which is PrEP use in the past 12 months, we can see that rebound again in more recent period, with a new high in 2022 of PrEP use, with almost 40,000 people using it in the last 12 months. So in summary, we've seen sustained low HIV notifications in Australia, and this response really has been characterised by partnerships between community, research and government sectors, and this decline and this response should really be celebrated. The low numbers attributed to high HIV testing, treatment as prevention, as well as PrEP and other prevention strategy coverage. We can't ignore that COVID has likely impacted the declines, with evidence of reduced risk behaviour, reduced testing, but also the restrictions on the movement of people. We've seen that the decline is greatest among people reporting male-to-male sexual contact, and the ongoing high proportion of late diagnoses is a concern, and it highlights the importance of accessible and timely testing. But I think now we need to remind ourselves that it's not the time to withdraw efforts, that we're talking about being crucial to sustain and enhance the response to HIV in Australia. We need to ensure equity of care and prevention in all populations so that we can ensure we continue to drive down transmission, but for people with HIV, that the appropriate support and treatment is in place for them as well. So finally, there's a huge number of people to acknowledge as well, particularly Jonathan King, for ensuring that these data are available in time, the states and territories, Rebecca Skye and Andrew Grillick, who's here in the audience, and Ben Babington and Doug Fraser for the PrEP data. So thank you very much.
So we'll open up for questions. Again, you can enter those online, but please come to the microphone and ask. So Skye, thanks. That was a great presentation. So you pointed out a number of impacts of COVID. I could ask a technical question. Do you think COVID at all impacted on the quality of the data that you collected? Given that health departments are preoccupied with other things, do you think the data is as reliable as it has been in previous years?
It's a good question. And I think we are very fortunate to have very dedicated surveillance officers in all of the jurisdictions who work really hard on these data. I think it's important to remember with the HIV data, we constantly revise them. So even if potentially there were some concerns during the peak of COVID with the capacity of health departments to report those data, we, and when I say we, Jonathan King works really closely with the jurisdictions to go back and check those data each year. And so you might see small changes year on year where those data are updated and corrected. So I think we can have more confidence that the data collected for 2022 have had an opportunity to update those data and ensure that they're reported appropriately. And that might include a lag from reporting clinicians. It might include completing some of the data fields that were missing before. So I am confident in the surveillance officers and the system we have in place that retrospective updating of data all the time ensures we have the highest quality data available.
Bridget.
Thanks, Skye. That was a fantastic presentation. I've got a question just about the reporting of the transgender people, because I noticed those flat pink lines. And is that because people are being counted as men and women, and because the surveillance data isn't doing a kind of two-step gender recording process?
Thanks, Bridget. So we have changed it recently. As you've highlighted, it has been a limitation of previous data collection where we didn't have the two-step process, but that has been implemented recently. We've only had a few years of that data collection, so it's hard at this point to compare it, but there is a plan to do an evaluation of that data collection look, and we certainly have seen an increase in that transgender identification through that two-step process. So as you say, asking sex assigned at birth and then gender as a second component, so we can combine those fields together.
Thanks.
So there's a question online asking about the late diagnoses and the proportion that are from overseas, and whether that's part of whether that is impacted upon by the application for visas and the processes associated with that.
Yeah, so I think Aaron and others can probably comment more on this, but there's certainly, we have a lot of room to move and progress to make in Australia around visas and access to that. And I'm sure that fear generated of that does stop people getting tested and can lead to an HIV diagnosis. There's also concerns around legal frameworks in Australia and a lot of work further to do to remove those barriers as well to ensure that people are accessing treatment.
Hi, thank you, Skye. Thank you for the presentation. It's really exciting to see the progress that we're making towards virtual elimination of HIV acquisition in Australia. Just so I'm understanding this right, I was wondering if you could help me. So the slide that you had about HIV notifications of people who had previously been notified that they were living with HIV overseas, would it be correct to subtract that number from the total HIV notifications in Australia to say, or are they different?
They're two separate data sets.
Okay.
So we do, when Richard Gray does the mathematical modelling to determine the number of people living with HIV, both of those go into the denominator. So in that one, we see both people previously diagnosed overseas and the first ever diagnosis. But the first slide I presented is a separate data set to the one with people previously diagnosed overseas.
Okay, so it'd be on, those notifications would be on top of?
That's right.
Right.
Yeah.
Thank you so much.
Meg?
Yeah, thank you. Really wonderful presentation and exciting to see the data. I had a question just regarding the fact that around the world, people are using 95, 95, 95 and sort of programmatic and service targets. Have you also put the data across your service targets and looking at all the service programmatic coverage? Because I do think those elements are important for a framework of elimination as we go forward.
Yeah, so Meg, I didn't present the 95, 95, 95 today, only because we don't have the latest modelling data available. We've worked really hard to get these count data available in time for the conference, but the data from last year show that there was 91% of people diagnosed, 92% on treatment and 98% with suppressed viral load. We are working very hard to also disaggregate those data. So as you've said, we're not just looking at that national level, but we're understanding when we break down into key populations, the spread geographically as well, where some of those differences might be, where some of those gaps are. For example, if we look at the undiagnosed proportion, we know that it's up to 25% in people born in Latin America and Southeast Asia, whereas overall it's 9%. So there is disparity there when we start to look at it in more detail.
So there's another question online about doing things more efficiently. And so what do you think of the concept of incorporating HIV testing into routine STI testing?
I'd say it's already in the guidelines, but so Australia's national guidelines, STI testing guidelines do recommend that when a chlamydia and gonorrhea test is done, a syphilis and HIV test is done at the same time. I think the testing coverage figures suggest that's probably not being done everywhere yet. But yeah, I think that's both an efficiency, but also just a normalisation of sexual and reproductive health, that when you go to talk about sexual health, but all of these tests are included in a comprehensive STI screen.
And then there's, I think what will be the final question is, could you estimate how much of the recent decline in infections is attributed to decreased male-to-male sexual contact rates during COVID-19?
That's a really tricky one to finish on. I'm not sure I could estimate that. As I say, we know from behavioural surveys that there was a reduction in risk behaviour during COVID lockdowns, but I couldn't tell you what that means in terms of reduction in transmission. And potentially, if there were cases during that period, we haven't seen them yet come through in surveillance data, but I wouldn't want to speculate.